Parathyroid is the gland of calcium homeostasis. Serum calcium level ke maintain করাটাই হচ্ছে প্যারাথরমোনের কাজ। নেক্সট, চারটে প্যারাথাইরয়েড গ্ল্যান্ড আছে, দুটো সুপিরিয়র দুটো ইনফিরিয়র, কিন্তু ডেভেলপমেন্টালি সুপিরিয়র ইনফিরিয়র নামেই বোঝা যাচ্ছে, সুপিরিয়রটা উপরে থাকবে, ইনফিরিয়রটা নিচে থাকবে, এর মধ্যে কোনো রকেট সায়েন্স নেই। প্রবলেমটা অন্য জায়গায়, ডেভেলপমেন্টালি সুপিরিয়রটা অ্যাকচুয়ালি ইনফিরিয়র আর ইনফিরিয়রটা অ্যাকচুয়ালি সুপিরিয়র। The superior arises from the fourth pharyngeal pouch and the inferior arises from the third pharyngeal pouch. তার মানে একটা যদি নিচে হয় সেটা উপরে উঠবে, আর যেটা উপরে উঠবে সেটা নিচে নামবে। আর they develop between 5th and 12th weeks of gestational life. They vary. The location of parathyroid glands vary but are symmetrical. মানেটা কি দাঁড়ালো? সুপিরিয়রটা এখানে থাকতে পারে, এখানে থাকতে পারে, এখানে থাকতে পারে, কিন্তু দুটো সাইড একই লেভেলে থাকে। একইভাবে ইনফিরিয়রটা উপর নিচে অনেক জায়গায় ভ্যারি করতে পারে, দুটো সাইড সিমেট্রিক্যালি থাকবে। ক্লিয়ার? All the parathyroids are supplied by the inferior thyroid artery. এটুকু আমার জানলে চলবে। নেক্সট, আমি যদি এবার ইনফিরিয়র প্যারাথাইরয়েড গ্ল্যান্ডের লোকেশন নিয়ে ভাবি, আনডিসেন্ডেড ওপরেই থেকে গেল, অ্যাবাভ দ্য ইনফিরিয়র থাইরয়েড আর্টারি 2% থাকে, বিলো দ্য ইন্টারসেকশন অফ ইনফিরিয়র থাইরয়েড আর্টারি অ্যান্ড রিকারেন্ট ল্যারিঞ্জিয়াল নার্ভ 3% কেসে থাকে। 56% is related to the lower pole of thyroid, 2% is intrathyroidal, 28% is in the thyrothymic tract, আর 9% is mediastinal। কিন্তু আবার কি বলেছি, রাইট আর লেফট সাইডে সিমেট্রি থাকবে, রাইটটা এখানে লেফটটা এখানে হবে না। নেক্সট, একইভাবে সুপিরিয়র প্যারাথাইরয়েড গ্ল্যান্ডেরও ভেরিয়েশন হয়, ইট ক্যান ইভেন লাই ইন দ্য ক্যারোটিড শীথ, বাট mediastinal লোকেশন অফ সুপিরিয়র প্যারাথাইরয়েড ইজ ভেরি রেয়ার। It around the intersection of inferior thyroid and recurrent laryngeal 77%, the commonest site. এছাড়া আপার পোল অফ থাইরয়েডেও যেতে পারে, ইন্ট্রাথাইরয়েডাল যেতে পারে, আর প্যারাইসোফেজিয়াল একটা টাইপ হতে পারে। নেক্সট, কি বলেছি একটু আগেই, ক্যালসিয়াম হিমোস্ট্যাসিস মেনটেন করা। ইট প্রডিউসেস এ 84 অ্যামাইনো অ্যাসিড পেপটাইড হরমোন, যেটা ক্লিভড হয় ইনটু এন ইনঅ্যাক্টিভ টার্মিনাল যাকে বলে সি টার্মিনাল, আর একটা অ্যাক্টিভ টার্মিনাল যাকে বলা হয় এন টার্মিনাল। Half-life of the circulating molecule is 3 to 5 minutes. আর প্যারাফলিকুলার সেলস অফ থাইরয়েড সিক্রিট ক্যালসিটোনিন। থাইরয়েড পড়াবার সময় ক্যালসিটোনিন নিয়ে কথা হচ্ছিল, মার্কার ফর মেডুলারি থাইরয়েড ক্যান্সার। দিস ইজ এ ফিজিওলজিক্যাল অ্যান্টাগনিস্ট টু প্যারাথাইরয়েড হরমোন, ক্যালসিটোনিন। নেক্সট, এবার তাহলে প্যারাথাইরয়েড ফিজিওলজিতে আমার কি দাঁড়ালো, সিরাম প্লাজমা কনসেন্ট্রেশন যদি বাড়ে প্যারাথাইরয়েড গ্ল্যান্ড সাপ্রেসড হবে, যদি সিরাম ক্যালসিয়াম লেভেল কমে প্যারাথাইরয়েড গ্ল্যান্ড অ্যাক্টিভেটেড হবে, দ্যাট উইল সিক্রেট প্যারাথাইরয়েড হরমোন। প্যারাথাইরয়েড হরমোন কি করবে, ক্যালসিয়াম মোবিলাইজ করবে ফ্রম দ্য বোনস, তার মানে বোনস উইল বিকাম ব্রিটল। যত বেশি ক্যালসিয়াম বোনের থেকে তুলবে বোনটা উইক হবে, রেনাল টিউবুলার অ্যাবজর্পশন অফ ক্যালসিয়াম বাড়িয়ে দেবে, আর অ্যাক্টিভেটস ভিটামিন ডি, which in turn increases the absorption of calcium from the gut. All three leads to increased calcium. তাহলে আবার কি দাঁড়ালো, প্লাজমা ক্যালসিয়াম কনসেন্ট্রেশন যদি কমে যায় প্যারাথাইরয়েড অ্যাক্টিভেটেড হলো, এটা হলো আমার প্লাজমা ক্যালসিয়াম বাড়লো। আবার যেই প্লাজমা ক্যালসিয়ামটা বাড়লো ও ডাউন রেগুলেট করবে প্যারাথাইরয়েড গ্ল্যান্ডকে, the secretion will come down. প্রত্যেকটা হরমোন সিক্রেশনই পড়েছিস একটা নেগেটিভ ফিডব্যাক ব্যালেন্সে কাজ করে, বাড়লে লেভেল কমে, কমলে লেভেল বাড়ে স্টিমুল্যান্টের, সেটা থাইরয়েডের ক্ষেত্রেও সত্যই। সেক্ষেত্রে স্টিমুল্যান্ট টিএসএইচ, যদি না টিএসএইচ সিক্রেটিং টিউমার হয় ইন দ্য পিটুইটারি, তাহলে একমাত্র কন্ডিশন যেখানে টিএসএইচ আর থাইরয়েড হরমোন দুটোই বাড়বে। আদারওয়াইজ একটু গরম লাগছে, এসি টেম্পারেচার একটু কমানো যায় কি? চলছে না, না? আচ্ছা ঠিক আছে। নেক্সট, নেক্সট এবার প্রাইমারি 3 রকম হাইপার প্যারাথাইরয়েডিজম আছে। বেসিক্যালি প্যারাথাইরয়েডিজম নিয়ে আমরা সার্জনরা মেডিকেল ম্যানেজমেন্ট নিয়ে অত চিন্তা করি না। আমরা তখনই চিন্তা করি যদি কন্ডিশনটা ইজ অ্যামেনেবল টু সার্জারি। তাহলেই এবার মেডিকেল ম্যানেজমেন্টের জন্য ফিজিশিয়ান কেন আমার কাছে পেশেন্ট পাঠাবে? তোর কাছেই বা কেন পাঠাবে তুই যদি সার্জন হোস? আন্ডারস্ট্যান্ড বাংলা? Understand Bangla? Then speak out. Why are you quiet? Why are you quiet? Speak out, sir. I can't get it. Okay, if you face any problem, speak out. Okay? So what happens? Underlying pathology of primary hyperparathyroidism is a solitary adenoma, and you need to surgically excise that adenoma. That is the job. That's why it is a surgical disease. 2 to 4% of the patients have double adenoma. Whenever you are talking about a solitary adenoma, it must afflict at one gland. 4 glands cannot have a solitary adenoma, or 2 glands cannot have a solitary adenoma. And if there is double adenoma, then the question arises that in those 2 to 4% patients, whether 1 gland is affected or 2 glands are affected. Okay? Now what happens? Multiglandular disease is seen in 15% patients, usually sporadic. Maybe familial. I talked about men 2A, 2B, men 1. Parathyroid, pituitary, parathyroid, pancreas and pituitary, and also pheochromocytoma, the 4 P's. Okay? Come in various permutation combination. In men 1, men 2A and men 2B. Now, only known risk factor is prior neck irradiation. There are no other known risk factor. Next. So, these patients can be symptomatic and asymptomatic. When there is a solitary parathyroid adenoma, which is producing parathormone, and the patient is getting elevated serum calcium, the patient may develop symptoms, may present without symptoms. Most patients present with hypercalcemia with elevated PTH because the downregulation is gone because of the adenoma producing excessive amount of PTH. Am I clear? Just physiologically I told you what happens when the plasma calcium goes up, there is downregulation and the parathyroid hormone secretion comes down. But this negative feedback goes out of the way, because the adenoma is producing excessive amount of PTH. So here is the condition where there will be elevated serum calcium but still elevated serum parathyroid hormone. Am I clear? Next, vague constitutional symptoms, fatigue, muscle weakness, depression, some mild memory loss on questioning. Now, what? Patients are typically associated with hypercalcemia and decreased bone density on DEXA scan. I just told you what does parathormone do? They resorb calcium from the bones, that means the bone density comes down. So, there may be features of osteopenia. Next, and the symptomatic patients, the most common presentation is kidney stone. Postmenopausal patients often present with osteopenia, significant osteoporosis in the distal third of radius and minimal reduction in lumbar spine. And osteitis fibrosa cystica due to increased bone resorption leads to cyst-like lesions in the bones. Okay? And as because the bones are getting weaker, as there is osteopenia and osteoporosis, the chance of pathological fractures lies. What is pathological fracture? Fracture due to trivial trauma. Normally, which should not result in a fracture. Those type of trauma result in fractures. Okay? Now, and often there is distal tapering of clavicles and salt and pepper appearance in the skull on X-ray. Next, may present with pancreatitis because hypercalcemia can cause pancreatitis. Band keratopathy, of course in cornea, calcium deposition, if present is pathognomonic of this disease, but rarely found nowadays. Rarely the patients present with hypercalcemic crisis. I will deal with it later. And so it is called bones, stones, abdominal groans with psychic overtones. This is the classical description of hyperparathyroid, primary hyperparathyroidism. কি এত ঘান্নারা কি হয়েছে? Actually এটা copied from belly love. belly love এরকম গল্প দিয়ে বই লেখে যেটা মনে রাখতে সুবিধা হয়. To describe Paget's disease of bone, he wrote one line. An old man walking in the streets of London with increasing head size, decreasing stick size, turning a deaf ear to your call. Now think, old man, elderly, man, male, increasing head size, the skull increases, হাত পা বেঁকে যায়, the legs and bend, so the stick size decreases and becomes deaf. The clinical features is finished. এটা ভালো লাগে না এগুলো? একটা কথায়, concise, by a single sentence, and this is how they describe this. Bones, stones, abdominal groans, and psychic overtones. Depression, anxiety is often there. ব্যাপারটা হচ্ছে belly love এর প্রবলেমটা হচ্ছে when we were students, belly love was a perfect textbook for undergraduates. But today belly love has increased so much that it has become too much for the undergraduate and too little for the postgraduate. Na ghar ka, na ghat ka. That is the problem. But when we were students, it was a fantastic textbook for undergraduates. The same with Atlas orthopedics. When we were students, around 30 years back, it was a fantastic textbook for undergraduates. Now it is too much for the undergraduate, too little for the postgraduate. That is the problem with these books. In attempt to put more information, the authors are miscalculating how much, what is good for undergraduate and what is sufficient for a postgraduate. তাহলে hypercalcemic crisis এ কি হয়? যখন the level of serum calcium is more than 3.5 millimole per liter or 14 mg per deciliter or more. That is defined as hypercalcemic crisis, acute confusion, vomiting, anuria, and severe dehydration. This is the presentation. এই পেশেন্টকে ইমিডিয়েট ট্রিটমেন্ট করতে হবে। কেন? এর ইসিজি চেঞ্জেস এসে যায়, prolonged PR and shortened QR, and all this means rhythm disturbances coming settling in, can get rise to life-threatening arrhythmias. আর কি? আর ক্যালসিয়াম যখন মোর দ্যান 4.5 millimole per liter or more than 18 mg per deciliter, it may result in coma. Next, এবার তাহলে differential diagnosis কি? All other causes of hypercalcemia? All other causes of hypercalcemia is the differential diagnosis. Endocrine hyperparathyroidism, thyrotoxicosis, pheochromocytoma, renal failure হতে পারে, secondary hyperparathyroidism, tertiary hyperparathyroidism যেগুলো পরে আসছি আমি, malignant disease, systemic metastatic disease, multiple myeloma, lymphoma, excessive vitamin D ingestion, vitamin A intoxication, milk alkali syndrome, aluminum intoxication, sarcoidosis, tuberculosis, hypercalciuric hypercalcemia, Paget's disease of bone, lithium, all these are the differential diagnosis. Clear? But the thing is, elevated parathyroid hormone along with elevated serum calcium is a very important finding. Next, একটু আগেই বললাম, তাহলে diagnosis is predominantly biochemical because a large section of the patients are asymptomatic. Accidental detection are low serum phosphate in the setting of normal serum creatinine and vitamin D. 24-hour urinary calcium may be normal or elevated. কেন আমি 24-hour urinary calcium করব? To exclude familial hypercalciuric hypercalcemia. নর্মালি হাইপারক্যালসিমিয়া হলে হাইপারক্যালসিউরিয়া তো হওয়া উচিতই, এটা নর্মাল, কিন্তু ওইটাতে আরো বেশি হয়। টু এক্সক্লুড দ্যাট, তার ক্রাইটেরিয়া আছে। আর সিরাম অ্যালকালাইন ফসফেটেজ মে বি এলিভেটেড ইন পেশেন্টস হ্যাভিং কনকমিটেন্ট বোন ডিজিজ। নেক্সট, এবার প্রশ্নটা হচ্ছে লোকালাইজেশন স্টাডিজ। একটু আগে কি কথা বলেছি? সার্জারি ইজ দ্য ট্রিটমেন্ট। তো সার্জারি করতে গেলে আমাকে তো 4টে প্যারাথাইরয়েড বাদ দিতে পারবো না। তার উপর প্যারাথাইরয়েডের location is variable. I cannot excise all the parathyroids and the location of the parathyroids is variable. So I have to locate the parathyroid and if possible identify the offending gland. That is the idea. Okay. Now you may ask me, so there is an adenoma, so I can easily identify it. Yes, if it is enlarged in size. If the adenoma is very small and yet to produce gland enlargement, how will I will know from naked eye? Earlier days it was said, when we were students, these localization studies were not too much positive, too much done, not done very widely available, neither they were very widely available and they were not done. And usually the experts used to say, the best localization study is a experienced parathyroid surgeon. That was what it was said. The fact is, in today's era of medical legal suing by the patients, that is gone. You have to localize it. Now, how can I localize? There are non-invasive and there are invasive. Invasive imaging is rarely needed nowadays. What are the non-invasive images? 4D CT, USG and Sestamibi scan. That is 2-methoxy, 2-methyl isopropyl nitrile. 2-methyl propyl isonitrile, sorry. I just struggle to remember this long thing. Okay. And the invasive, ultrasound or CT guided FNAC, parathyroid angiography, selective venous angiography for parathyroid gradient. This is a damn difficult procedure. Identify all the 4 by USG or CT, then identify their veins, collect blood from each of them, then find out. This is a damn difficult procedure. No wonder these are now obsolete with the advent of Sestamibi. Next. And the treatment is surgery. I have already talked about it. Now, I have told you there are a bunch of asymptomatic patients and there are a bunch of symptomatic patients. All symptomatic patients need surgery. Make no mistake. Okay. Now, there are many types of parathyroidectomy. There is total parathyroidectomy. Why? Because you have failed to localize, which is the offending agent. You explode the entire neck, take out all the glands, and we often call it 3.5 parathyroidectomy, which is subtotal. Take out half of one normal gland and implant it in the wrist. Okay? In the forearm, sorry, not wrist, in the forearm. Okay? Focused parathyroidectomy, identify that disease gland and do it only. Thymectomy should be done in patients, those who have associated men type 1. So, whenever you diagnose parathyroid, you have to investigate for men syndromes also, because they may be associated. Okay. Next. So, the symptomatic patients are dealt with. What about the asymptomatic patients? What about the asymptomatic patients? Should we operate? Should we not operate? Make no mistake. If a patient is asymptomatic, the first question he or she will ask you, Doctor, আমার তো কোনো কষ্ট নেই, আমি কেন গলায় কাটাতে যাব? I am not having any complaint. Why should I operate? This question is bound to come. So, sir, there must be certain indications, absolute indications where you need to operate. The problem is, whenever these indications come into place, that the surgery is not absolutely indicated, but some patients should be offered surgery, it differs from person to person. Suppose he may say, I will operate if the criteria serum calcium is this and this. He may say, no, I will operate if it is this and this. So, there must be some consensus. There should be some consensus. And these are the consensus guidelines. If it is more than 1 milligram per deciliter above the upper normal limit, serum calcium. Next is skeletal. the T score by DEXA scan is less minus 2.5 at lumbar spine, hip and other bones. Creatinine clearance is less than 60 ml per minute. 24-hour urinary calcium is more than 10 millimole per deciliter or 400 milliliter per day. Age is less than 50 years. Okay? These are the indications of surgery in asymptomatic patients. Tale ki daralo? Whenever we talk of primary hyperparathyroidism, jodi summarize kori, porikka ekta 5 নম্বরের short note elo. There is a 5 short note carrying 5 marks in the exam. I don't believe somebody will ask you to write a long question on this. I don't believe. If it is given, I must say that will be a damn difficult question. And the paper setter should be sued, should be penalized. Okay? So, whenever you are short note on primary hyperparathyroidism, first write the definition. Hypercalcemia due to a pituitary adenoma, usually solitary, 15% multiple glands, 2 to 4% double adenoma. Then presentation, symptomatic, asymptomatic. Typical presentation in asymptomatic patients, incidental detection, hypercalcemia with increased parathyroid. Symptomatic patients, bone, stones, abdominal groans and psychiatric overtones. Now you derive it, increased bone resorption, weakening of bones, bone cavities, maybe bone pain, maybe pathological fracture. Now you elaborate it. Stones in the kidney. Okay? And because of stones, there may be abdominal pains, that is abdominal groans, anxiety, depression. Very easy. Now diagnose. I have already told you, 24-hour serum calcium excretion is another, you have to do it. Then indications of treatment is surgery, whom we should operate in all patients of who are symptomatic, and in asymptomatic patients. If you don't recall this chart totally, just write it this way: very high serum calcium, very low bone density. I cannot put zero dite parbo na, ek to dite hobe, tai to ek to dite hobe, ke deয়, mufte to asche na. Okay? And prior to surgery, localization studies. If you cannot remember all those, just write 3. Invasive, non-invasive, mone nei, USG, CT, always can be done. And Sestamibi, just koshto kore ekta kotha mone rakha. Just remembering one word. If you write this for a 5-mark short note, I am bound to give you at least 3.5. At least 3.5 I am bound to give you. Or kya chahiye? তাই না? Okay, next. এই যে এইটা হচ্ছে এই চার্টটা মনে রাখতে পারলে হয়ে গেল। কিরকম দাঁড়ালো? প্রাইমারি হাইপারপ্যারাথাইরয়েডিজম বায়োকেমিক্যালি আমি ধরেছি, সিস্টেমিবি আর আল্ট্রাসাউন্ড করলাম, কনকর্ডেন্ট ইমেজিং মানে ইমেজ আমাকে ধরে দিল কি আছে। প্রি অপারেটিভ মার্কিং করে নেবো উইথ ইউএসজি, এটা সাহেবরা করে, আমাদের দেশে এইসব স্কোপ আমরা খুব একটা পাই না। মিনিমালি ইনভেসিভ বা এই ফোকাসড প্যারাথাইরয়েডেক্টমি বা মিনিমালি ইনভেসিভ প্যারাথাইরয়েডেক্টমি এইসব করে দেওয়া যায়। ক্লিয়ার? যদি ডিসকর্ডেন্ট ইমেজিং ধরতে পারলো না, সেস্টামিবি আর ইউএসজি করে, ও দে ক্যানট টেল ইউ, ডু এ 4D CT. Even you are not clear, then do a 4-gland exploration. After 4D CT you are clear, 4D CT localizes, then mark it with a USG and go for localized or focused parathyroidectomy. Okay? Mind you, it is a difficult operation because lots and lots of difficult structures are along it. There is thyroid in front, highly vascular, recurrent laryngeal nerve and inferior thyroid artery all are closed. This is a difficult operation, make no mistake. ঠিক আছে? Next, medical management of primary hyperparathyroidism. একটু আগেই তো বললাম ট্রিটমেন্ট ইজ সার্জারি, তাহলে মেডিকেল ম্যানেজমেন্টের কথা এলো কোথা থেকে? Indicated in these 3. Patients who are not fit for surgery, 90 বছরের বৃদ্ধ, হার্টের গন্ডগোল, লাংসের গন্ডগোল, দেখে বুঝতে পারছিস টেবিলে তুললে আর নামবে না, Do you understand what I tell? The patient is so old, frail and having multiple comorbid factors that if I operate, he is not going to survive. That patient is unfit for surgery. Okay? Old, frail, may not be old. A 50-year-old man with uncontrolled sugar, with dilated cardiomyopathy, with an ejection fraction of 28%, with bilateral lung fibrosis is also a bad candidate. So these patients, surgery should be avoided in these patients unless absolutely indicated. Absolutely indicated, stab injury. He is going to die. Let us try to save him. If God saves him, he will go home. Okay? Now, what are the aims of treatment? Aims are to prevent skeletal complications. Because of all these are the most dangerous things. Because of the propensity to fractures. So what you can do, bisphosphonates, they reduce osteoclast activity. Okay? This is the medical management. And the next indication is failed surgical intervention. You have tried to operate, there was no visible adenoma, the localization studies have failed, you have operated and you have taken out the wrong gland. And long-term management of parathyroid carcinoma, which is not amenable to surgery. That is advanced parathyroid carcinoma, which has spread to others, which is not amenable to resection. Inoperable. Okay? Next. HRT in women is also a part of medical management. And calcimimetics like sinacalcet, they activate the extracellular calcium sensing receptor on the parathyroid cell surface. So, parathyroid hormone কিছুটা হলো কমানোর চেষ্টা করছে। ক্যালসিয়াম কি আছে? প্যারাথাইরয়েড হরমোন ক্যালসিয়াম কমলে তো কাজ করবে। এবার প্যারাথাইরয়েড হরমোন রিসেপ্টরটাকে প্যারাথাইরয়েড গ্ল্যান্ডের রিসেপ্টর senses the lower serum calcium. So what they do, these drugs occupy those calcium receptors on the parathyroid. As a result, what happens? The normal portion of the gland reduces secretion. Some reduction in calcium may happen. Next, treatment of hypercalcemic crisis. I was talking about hypercalcemic crisis, dehydration and all those things. If the patient is dehydrated, you have to dehydrate. Very simple. In excess of 100 ml per hour fluid therapy. But during fluid resuscitation, keep in mind the patient has a normal heart and normal kidney. If the patient is not having a normal heart with reduced cardiac output or reduced ejection fraction, and if you keep on pumping fluid, what may happen? The left ventricle will fail to eject all the blood, that is the right atrium will receive increased blood supply. That means the left ventricle will also get more blood, but it is failing to pump out all the blood that it is receiving. Anyway, it pumps out 2/3 of the blood, 65 to 70% is the ejection fraction. So some blood is staying in the left ventricle. Aste aste eta barche. So the blood in the left ventricle is getting accumulated, left atrium gets accumulated, back pressure, there is pulmonary edema. This is called congestive cardiac failure. Okay? And your kidney is not working properly, fluid that is going in is not going out properly, required amount, the preload is increasing on the heart, congestive cardiac failure. Am I clear? Other things, loop diuretics or furosemide to increase renal clearance of calcium, bisphosphonates and calcitonin. This is the treatment. Okay? Next, secondary hyperparathyroidism. This is also called renal hyperparathyroidism because it is almost always due to renal failure. Increased parathyroid secretion in response to deranged calcium homeostasis. There are two features which often the patients present with: osteitis fibrosa cystica and calciphylaxis. Luckily, this type of presentation is very rare. Now, what is the difference that we do? I have already told you, primarily due to chronic kidney disease. Because of hypocalcemia associated with chronic kidney disease, patients develop parathyroid hyperplasia. Biochemical diagnosis made by low or normal serum calcium with an elevated parathyroid. Very simple, you cannot fill in the tanks with your taps open. Can you fill in the tanks up in the roof by keeping all the taps open? Parathyroid is pumping in parathyroid, but calcium is going out through the kidneys. So serum calcium may remain normal or even low, but the parathyroid is high. Next is phosphate levels are high, vitamin D levels are usually low. Localization studies are not required because you don't have to operate on the parathyroid. Because what you have to do is renal transplant. Remove the cause and it gets cured. তাই তো? আমি প্যারাথাইরয়েডেক্টমি করে করবোটা কি? কিডনিটাই তো খারাপ। So renal transplant. But use of calcimimetics has reduced the need for surgical intervention, and in some patients, even after renal transplant, some patients may need subtotal parathyroidectomy. That is altogether a separate entity. I am coming later on. Next. Calciphylaxis কাকে বলে? Calcific uremic arteriolopathy. Disseminated calcification occurs leading to vascular calcification, skin necrosis. Painful pruritic cutaneous lesions predominantly in the lower extremities. Calcification in the arterioles lead to ischemic necrosis and gangrene. This leads to sepsis and death. Most patients have an elevated serum calcium into phosphate product. Calcium, serum calcium and serum phosphate is multiplied levels are multiplied and the product is higher than normal. Serum parathyroid levels are not always extremely high. Prognosis poor, 87% mortality. Urgent parathyroidectomy is needed in these patients. একটু আগে বলছিলাম when surgically indicated. If the patient presents with calciphylaxis, urgent parathyroidectomy is indicated. Clear? Next. Now the question is indications of surgical intervention in secondary hyperparathyroidism. Persistently high serum parathyroid, hyperphosphatemia or hypercalcemia, which is refractory to medical management, and the volume of largest gland is more than 300 to 500 cc or cubic millimeter. Clinical findings, এটা দরকার পড়বে না তোদের। সেকেন্ডারি হাইপারপ্যারাথাইরয়েডিজম আমরা কি দেখলাম? রেনাল ফেইলিয়ারের জন্য 4টে প্যারাথাইরয়েড গ্ল্যান্ডের হাইপারপ্লাসিয়া। Hyperplasia of the parathyroid glands due to renal failure and all other things. Now I have done a renal transplant. Normally it should come back to normal, but the problem is even after renal transplant, the 4 hyperplastic glands continue to pump in even more parathyroid. Okay? That is tertiary hyperparathyroidism. Clear? Renal failure, calcium বেরিয়ে যাচ্ছে, তার জন্য প্যারাথাইরয়েড এক্সট্রা কাজ করছে, প্যারাথাইরয়েড হাইপারপ্লাসিয়া হলো। নর্মালি আমি যখন কিডনি ট্রান্সপ্লান্ট করব, আমার তো এটা আস্তে আস্তে নর্মাল হয়ে যাওয়ার কথা, কিন্তু এটা হাইপারপ্লাস্টিক হয়ে গেছে। এবার ও কিডনি নর্মাল হওয়ার পরেও ও এক্সট্রা কাজ করে চলেছে। This is now called tertiary hyperparathyroidism. Am I clear? The thing should have been cured by renal transplant, but that did not happen. The parathyroid, which has undergone hyperplastic changes, is pumping in more parathyroid hormone. Okay? That is tertiary hyperparathyroidism. Okay? The treatment is elevated total or ionized calcium, elevated serum parathyroid, reduced phosphate. And this must be seen at least 1 year post-transplant. You have to give it the time to settle. You just can't operate, I have done the transplant today and tomorrow all the biochemical parameters will be same. It should not be. It cannot be. So you have to give time. So even after 1 year after renal transplant, if you find that serum parathyroid is elevated, serum calcium is elevated and serum phosphate is down, then and only then you have to think about a tertiary parathyroidism. Localization studies are not required usually. Focused neck ultrasound may be done and treatment is subtotal parathyroidectomy. In primary hyperparathyroidism, localization studies were required. Why? Because the offending agent is usually a single gland. In secondary, parathyroid surgery is not required unless there is calciphylaxis. If there is calciphylaxis, you have to do urgent parathyroidectomy. All the 4 glands have undergone hyperplasia. So what is the point in removing one? Do a subtotal here also. All the 4 glands are involved. What is the point in localizing one and taking that out? No need. Do a subtotal. That is 3.5. The most normal looking gland should be divided into 2 and that rest can be implanted here, or during dissection leave half of that gland. Okay? Next. Now what are the indications of surgical intervention in tertiary hypercalcemia? That means the same thing comes again and again. Every patient does not require surgery. Surgery is indicated in certain indications. And what are they? Remember it like this. When serum calcium is excessively high, when there is massive bone density problems, nodular hyperplasia of the parathyroid glands and impaired graft function. Renal function, renal transplant has been done and the graft is not working properly. Next, parathyroid carcinoma is a very rare cancer. Less than 1% of all hyperparathyroidism is due to carcinoma. History of previous neck irradiation. And I have told you again and again, whenever there is a carcinoma, you have to stage the disease. Staging depends on 3 things: size, local spread, lymph nodal space, metastatic spread. Okay? So image accordingly. What are the images that will give you idea about local spread and lymph node spread? USG and CT scan of neck. No rocket science. Now where it can spread? Lung, liver, bone. To detect lung, HRCT, thorax or X-ray chest. Liver, USG or CT of abdomen. Bone scan. এই ইনভেস্টিগেশনের জন্য বিরাট কিছু মনে রাখার দরকার নেই. More or less these are the constant. These are the constant. And if there are certain cancers which have more propensity towards brain metastasis, do a CT of brain or MRI of brain. Clear? That means to detect local imaging, to detect distant spread, distant imaging. And for almost all solid organ malignancies, treatment is surgery. I have told you again and again, exception is 2, where organ preservation becomes very important. One is larynx, because if the larynx is gone, you will lose your voice. So they try to preserve the larynx, but again today esophageal voice training is given to patients. And the other is anal canal. Because in carcinoma anal canal, if you remove the anus, the patient will be left with a permanent end colostomy. Okay? Otherwise, in almost every solid organ malignancy or even in hollow viscera malignancy of human body, the treatment is surgery. The best treatment is surgery. And the best prognosticator is the completeness of the surgical specimen. Whether the entirety of the gland has been resected along with the lymph node basin. If you can resect it totally, that gives the best surgical outcome. And remember it, the first chance is the best chance. Okay? That is same thing. And control hypercalcemia first before taking surgery. Otherwise, the patient may develop hypercalcemic crisis.